But our first speaker is Dr. Mai Baker. She is coming to us. She's a professor in the Department of Pediatrics and the director in the Newborn Screening Laboratory at the University of Wisconsin School of Medicine and Public Health. She has 15 years of experience in routine newborn screening with a specific interest in successful track record applying emerging technologies to implement new screening tests for disorders and to improve ongoing screening. She's one of the leading scientists who made Wisconsin the first state in the nation and the world to implement the newborn screening for SCIDs, severe combined immunodeficiency, in 2008, as well as developed and implemented the cystic fibrosis newborn screening, which is how we were introduced by our colleagues at the Cystic Fibrosis Foundation. And she is really a force to be reckoned with. When you talk about newborn screening and you say, well, we're working with Mai Baker, they say, oh, you're good, because you're working with Mai Baker. And our next speaker, who I'll introduce when she comes up, is also equally as impressive and is going to be talking to us about her newborn screening efforts at RTI in North Carolina, but for her talk, I will introduce her separately. So, Dr. Baker.
Hello, everyone. So, as a newborn screening person, I will say myself newborn screeners, I have to start slides newborn screening. So I really want to emphasize newborn screening is not just test. So when we think about the developed newborn screening assay, we really need to think about the newborn screening as a system. So we said, let's try to adding on Angelman syndrome to newborn screening. And if I may say that, I will say integrate newborn screening for Angelman syndrome to the ongoing existing system. The reason I say that is we need to identify what we have done, we can leverage it, right? What the things we haven't done, we need to overcome the challenge. So allow me just walk you through the process and how we put it into the newborn screening for Angelman syndrome context. So here, everything we start, we call pre-analytical. So for newborn screening, and I am really want to address is a public health system. I'm not talking about research. I'm talking about implementation. We had heard so much about advance in therapeutic field. We need to be hurry up. We need to be ready when the FDA approve in place, right? So first, forward education. So we need to start to tell the parents, and everybody here in this room is very knowledgeable about the Angelman syndrome, but we need to let public know that. And fortunately, FAST has done this for us. I did my study, I went to the website, very impressive. Compared with other genetic conditions in the current newborn screening panel, I have to say, Angelman is much, much more complicated, but they have the illustration, tell different type. I simply think when our website talk about Angelman syndrome, I'm just do the link. I don't need to do again, right? So it's there. So come to the specimen collection for Angelman syndrome, we will use the dry blood spots. It is already in the system. And even better, we don't even need another spec cards because I will tell you how we do use the DNA already existing for other disorders. We can just take another step. So in terms of the I think in newborn screening, not only we screen disorders, we have the timeless. So the goal is with newborn screening, after you collect samples at the age of 24, 40 hours, you also need to transport the samples to our laboratory within 24 hours. Then in the laboratory, we have another couple days to do the testing. So in the day 5, you will know it's a screening positive or negative. And of course, come to the testing, and Angelman syndrome is new. So it's why we need to develop the assay. But we also have something we have done, we can leverage that. The next slide, I will mention that to you. So another concept we call the short-term follow-up. What that means the laboratory, the program, you identified the newborns is not enough. So it's our responsibility be sure the identified positive the newborns be followed up, including both confirmatory test and clinical care. So that is why we call program, I don't say just laboratory. So I think it's important. Come to long-term follow-up as advocacy, I was stunned by how much has been done by this group. From yesterday, all this platform, long-term follow-up, you are ahead than so many newborn screening disorders, even we are screening for now. So I have reason to be excited, right? So I think the way is really multidisciplinary and we can do together. And this morning I was stopped by the Harvard, the booth. I said, I really encourage everybody have done registry, has done long-term follow-up, start think about the program for long-term follow-up for the Angelman syndrome identified through newborn screening. They have a lot of nuances, different, but you have the structure in place. So with that, let's go to the second slide. So here is the imaging. It's a Wisconsin newborn screening program, but I can assure you it reflects nationwide situation. I list all the disorders here, and I emphasize the two in green. It's the newborn screening for SCID, and Allison mentioned that, and also the spinal muscular atrophy. The reason I mentioned these two disorders here is let you know we have done this before. The technology, the same instrument, we will use this for Angelman syndrome. So every single state in the United States, they have real-time PCR machine. And the staff members have been trained to do the real-time PCR. So I will view them as the facilitator for adding on, integrating Angelman syndrome. So we have a lot to be hopeful, and we had a good foundation. And also I mentioned that because this is I feel very lucky in my career, and the SCID is the first disorders in the newborn screening setting use a molecular tool as a first-tier newborn screening. I was there. So SMA is the first newborn screening disorder we use a genetic tool, and I was able to be part of that. So now, closely follow up Angelman syndrome. So the DNA we isolated for these two disorders, we can readily take another step to do the Angelman syndrome. So that's why in my mind at least, when we start talking about the newborn for Angelman syndrome. So here is the slides, and we indicate, so I think for family, for physician, I think we all know, at a clinical setting, when you suspicious this kid have Angelman syndrome, the first molecular testing is methylation status assessment, right? So the newborn screening concept is take this to the newborn screening setting. The difference is that we don't know to have symptoms because at the newborn stage, everybody, you have to assume everybody is normal because largely they are normal. So the bar set different and the process a little bit different. First, the sample type is not whole blood, it's dry blood spots. So we use 3.2 centimeter disc that equivalent to 3.2 marked blood. From this, we have little DNA work with. So this is number one. Number two is high throughput. So in the clinical setting, the baby or child sick, you can assess one-on-one. But this, we have to do the larger scale. So the assay have to be scalable, and also the assay have to be robust. Think about a baby born every day. I cannot afford it the sample backlog at the lab, right? And we have to make every single sample works at first time. So this is a bar set in the way, and fortunately, we are there. So I mentioned the slides. You can tell the assay process. We use residual DNA from the testing for SCID and SMA, and do the bisulfur treatment. From there, and we set the multiplex PCR, which is exactly the way we do for SCID and the SMA. But you take another step. The step is not manual. You don't need to do anything except when you program the real-time PCR, you're adding on a couple steps. So the end of the PCR you do, we call the mutant curve analysis. So you will see the picture here. I like it. I hope you like it too. So it's discrete here. You see, if you have a 2 methylation and unmethylation pattern, you are okay. So if you have a 1 unmethylated one, you heard so much about Angelman syndrome, that's indicate you likely have Angelman syndrome. Or if you only have 1 peak, which is indicated blue, the methylation the ones, then you can have different disorders called Prader-Willi. So I don't want to take too much time on that one, but I think that's the situation. So I do mention that what the assay can do. We heard so many times, I don't think I need to even repeat. Deletion, UPD, ICD, right? But we do need to recognize they have a limitation. The limitation is the variance, we talk mutation, in the UPE3A. This form will not identified. So we need to know the limitation, and I can tell you, I already start design a different assay so we can take care another 10%. So that, I hope next year I can tell you the new assay. And I promise it's not just adding another assay. I want to have one tested platform can cover them all. But one part I want to say a little bit is the Mosaic system. So you heard so many. I think Allison actually did what I want to do. And I think come to the Mosaic system, I think is open for discussion. So in the newborn screening, public health, again, different than clinical diagnosis, we have to assess the benefit and harm. So the key things here is 40% Mosaic system, potentially have that, may not ever have a clinical symptoms. So in the newborn screening setting, we have so many different kind of scenarios. So when you identify this group of children, you tell parents, we really don't know you will have disease or not. We just wait to see. So we have a term for that called the disease in waiting. Or sometimes we say it's a vulnerable child syndrome. So you tell people, this is for public health realm, that is terribly important. And I don't have time to go into detail. I'm happy to talk to everybody. If the field, if the parents think that's important, we have evidence to indicate, identify them, it's more beneficial than the harm, and this assay can be easily modified to become quantitatively. We can do that. Technology, we can do that, but ethically, shall we do that? So we need to ask ourselves. So I'm very pleased with what we have, but I have one step to go. So for the clinical testing, not only you develop assay, you also have to validate it. I don't want to get details, and because our laboratory is a clear, certified, CAP accredited lab, so we have to do one more step. In order to do that, we do need find Angelman syndrome and Prader-Willi syndrome patient identified, ask them to contribute the dropout spots, so we can say our system can correctly identify them. So here is our effort to do the RB evaluation. So here, I really like the title. I hope you do too. We said early detection for better outcome. I don't think you argue with me on that. So we will have this simple flight, but we have the letter. The letter we want to do is through our health system, we can identify the children, and we already know how many there. So then myself and the care physician, so we will join the writing letter to the family, ask them, we will have the cards, little cards, and also lancet, so they can just at home and punch it and put the cards, mail to us. So we sent the RB and we went through some questions. I'm pleased to tell you, yesterday I got notification, RB is okayed. So we will continue to get samples coming in and to make to the next. So in summary, I do believe we have developed a high throughput and newborn screening assay for Angelman syndrome and Prader-Willi. And also the developed assay utilize leftover DNA and originally isolated for the screening testing for SCID and SMA. So this is called a cost-effective, right? And the third one is we developed is readily integrated to the current ongoing newborn screening program even for clinical follow-up. The reason we said that is because we have the SMA in place, so it will be the same doctor. We contact them. And I can tell you, our neurologist is very exciting, and our endocrinologist is also very exciting for Prader-Willi. So last but not the least, I think is the assay. I have a confidence that the validation process, we will expect 100% sensitivity and specificity for the methylation, the status change, the Angelman syndrome. So thank you. I think I have a small group, but we do good work. So I think Sean has been working with me for a long time, and he did all the laboratory testing. And Dr. Endelman and Dr. Hughes, they're neurologists, so they will help me recruit their patients. And Dr. Carroll is the endocrinologist. Thank you very much for your attention.